Hi, I'm Wong Kee Song from the Division of Gastroenterology and Hepatology at Mayo Clinic in Rochester, Minnesota. And on behalf of my co-authors and myself, we appreciate the opportunity to highlight the findings from our study entitled Outcomes of Double Balloon Endoscopy-Assisted Direct Percutaneous Endoscopic Jejunostomy Tube Placement. As background information, our group previously published the larger series on the outcomes of direct percutaneous endoscopic jejunostomy tube placement or direct PEJ tube placement using conventional enteroscopes. In that study, conventional push enteroscopic attempts failed in approximately 1/3 of patients due to limited instrument insertion and/or lack of adequate transillumination for direct PEJ tube placement. We surmise that double balloon endoscopy, or DPE, should facilitate direct PEJ tube placement by allowing deeper instrument access and finding a suitable site for direct PEJ tube placement in the jejunum. Indeed, in a small prospective pilot study involving 10 patients, we showed that DPE-assisted direct PEJ tube placement was successful as a rescue procedure in all patients who previously failed conventional attempts at direct PEJ tube placement. Therefore, on the basis of these prior studies, we shifted our clinical practice of direct PEJ tube placement using conventional endoscopes to that of DPE-assisted direct PEJ tube placement. The current study reports our experience on the technical success and adverse events related to direct PEJ tube placement via double balloon endoscopy in a large cohort of patients. Our study comprises 94 patients, and the most common indication for direct PEJ tube placement was gastroparesis. Altered gut anatomy was present in 38% of cases. In native anatomy, the DPE anchoring balloons and standard push-pull maneuvers were not activated until the tip of the instrument was beyond the ligament of Treitz. Excessive pulling and pleating of the small intestine was avoided during reduction maneuvers of the DPE scope. DPE insertion was limited to less than 150 centimeters distal to the ligament of Treitz in native anatomy. Once a suitable site was identified, the PEJ tube was placed using a standard PEG kit and the Ponsky pull-through technique. DPE-assisted direct PEJ tube placement was technically successful in 93% of patients, and the mean procedure duration was 33 minutes from endoscope insertion to PEJ tube in situ. Failure of the procedure occurred in 7% of patients, primarily due to limited instrument insertion in the setting of presumed adhesions. In the setting of small bowel angulation and fixation due to adhesions, direct PEJ tube placement would have failed regardless of the type of endoscopic instrument utilized. Post-procedural adverse events occurred in 9% of patients and were mild in severity, except for one serious adverse event of gastric interposition requiring surgical repair. In summary, DPE-assisted direct PEJ placement achieved high technical success rate and was relatively safe in a large cohort of patients. Prospective randomized trials are needed to assess the benefits and cost effectiveness of DPE-assisted direct patch placement relative to direct patch tube placement using conventional endoscopes. We thank you for your attention.